Good morning, everybody. I'm going to start now. Are you all comfortable? And can you hear me? Good. Thank you. A very warm welcome to NAP's annual conference. We've arranged, I hope you'll find out, a most interesting and stimulating day. And this has been arranged by a small band of people. And I would particularly like to thank Edith Todd, Moira Ochterlony, and Paul Devlin, our Chief Executive, for their great contribution to this. You'll have seen over the last year how busy NAP has been. We are increasingly being asked by policymakers, the government, professional organisations, the regulators, the General Medical Council, the CQC, educational organisations and researchers for our views on issues concerning patients and practices and how this affects the delivery of primary care. We believe that in matters concerning primary care, NAP should be the go-to, in inverted commas, in the words of one of our trustees, organisation of choice. But this cannot be done without the involvement of all of you. You are the intelligence, the energy, and the enthusiasm of this organisation. Thank you all for your hard work and willing participation. And now to begin the day. It's my pleasure to welcome our patron, Sir Dennis Pereira Gray, who is already known to most of you. Dennis is an extremely loyal supporter, and we're very grateful that he chairs our conference and provides such succinct summary that we all look forward to. Dennis, over to you.
Thank you very much, Madam Chairman. It's a great pleasure for me to be the patron of NAP. I take it very seriously, and it's a particular pleasure to be able to chair a conference as big and as wide-ranging as this one. So my first pleasant duty is to introduce for you the new president of the Royal College of General Practitioners. The presidency in that Royal College is elected by a secret ballot of the entire membership of the college, which is the biggest of all the medical Royal Colleges in the United Kingdom. Terry Kemple has been a GP in Bristol, where we knew each other for many years. He's always been very active in teaching and in quality assurance. And he has the notable distinction of being one of the very few general practitioners who not only did the Quality Team Royal College Quality Assurance Award, but then thought that that needed keeping up to date, and so he and his practice went through it 3 different times. So if there's a commitment to quality assurance, we have it before us today. So it's a great pleasure to welcome Dr. Terry Kemple.
Thank you, Dennis, and thank you, Patricia. And thank you for inviting me to come here today. We're particularly pleased because NAP have been our partners in this Putting Patients First initiative, which our current chair, Maureen Baker, has been running for 2.5 years. And it's come to some sort of fruition, so we're very grateful for our partnership with you in that. And NAP is very warmly regarded within our college. So, we need to talk about general practice. So GPs should be accessible. They should provide you the best treatments. You should get customer satisfaction. You should have real depth of care. You should have efficient and effective care, and you should have fair care for all. That's what should be happening. But what's the context in 2016? Well, increasing workload, an aging population, multimorbidities, transformation of risk factors in common life experiences into diseases, an overload of information and regulation, constant streams of technology developments, underinvestment and very low morale in primary care, not enough GPs and general practice nurses. I don't know how you're feeling that, but this is a real crisis that we're in. Increasing complaints, including increasing vexatious complaints by patients, increasing costs of medical indemnity for doctors, and basically too many reorganizations and changes undermining delivery of care. And even when they say they're not reorganizing things, they are reorganizing things. So for instance, Avon Health Authority, which used to exist in my area, disappeared, and now it's back, but now we call it an STP, and the Avon Council is back, but we're calling that a supermare. So they all come back. So this is the result. General practice, being no doubt about this, is currently in a crisis. So this is my declaration of interest. It's very important. I want you to read this very carefully. This is slightly more interesting. This is an infographic of my CV, which was presented to me when I retired. And so this is how I got here. I have 4 or 5 sabbaticals on the way, which I recommend to anybody. And then I can explain the get to the front, hold your arms up in the air and scream later on, which is a personal motto. Anyway, start with the case history. This is a tale of 2 brothers. One's aged 56, and he had squamous cancer of his right tonsil and spread to the lymph nodes, and he was treated with radical surgery, chemotherapy, and unilateral radiotherapy, but made a pretty good recovery. The sorts of side effects you'd expect, really dry mouth from the radiotherapy. Radiotherapy is the treatment that keeps giving for the rest of your life in some shape or form, but did quite well. And then his brother, who was 2 years older than him, 2 years later, got basically the same cancer and was treated at a hospital 40 miles away and had bilateral radiotherapy for some reason, but as a result had severe side effects, completely bone-dry mouth, had a fracture from the osteoradionecrosis of his jaw due to the radiotherapy, and had to have a transplant of his bone from his leg to his jaw, and has been in considerable pain, can hardly talk, and only can take fluids. Anyway, that's me and my brother. So is this just bad luck or just the usual variation in NHS treatments? Because it still seems a bit of a lottery at times. So in addition to the usual variation of healthcare throughout our health service, the UK now has 4 different NHS systems: England, Scotland, Wales, and Northern Ireland. And they're all going in slightly different directions, but despite the diverging health systems, we all have the same problems. And it's not just us, it's North America, it's Australia, all the countries have the same problems. So we can't blame any particular Minister of Health for it. These are other problems. So for a lot of us, healthcare seems a little bit out of control. There's a hydra of over-regulation, over-expectation, and overspending, and it just seems impossible. And the government feels that it's impossible to control as well half the time. So what's to be done? This is my real declaration of interest. Essentially, I used to be a GP until December, and now I do an occasional surgery just so that I can say I do an occasional surgery. But it's not like real work. And I have research and do appraisals and things like that, and I work in the college. So what's the underlying problem? Well, I think, and what I'm really going to talk about today, is quality improvement. So for over 25 years, quality has been in our vocabulary in general practice, but for reasons which are clearly not very well understood, it's not actually part of the core culture. People put it on one side, but they don't live it. So recently, the Academy of Medical Royal Colleges, which I think that's another thing you used to be chair of, isn't it, Dennis? Brought out a new document which says quality improvement, training for better outcomes. And the idea is we just have to train people better, because actually if you ask the people who aren't doing it, they say, well, if you give me better training, I'll do it. But actually, that's not the answer. There's something in our culture which resists quality improvement for some reason. So, as Dennis said, I've been very interested in quality for a long time, and these 5 questions are going to come up again and again today. So, all you ever have to do is ask 5 questions when you're trying to improve something. So, what are we trying to achieve? What do we know about it already? How will we know if we've been successful? What are the success criteria? This is a question which is hardly ever asked in healthcare. All right, we're going to have a change, but how will we know we've been successful? Then the next question is, well, we'd like to do this, but we've only got this amount of money and I've only got so much time. So what can we actually do with the resources we've got? And then, because you won't get it right, how do we review this process? So these questions will come up time and time again in the course of this lecture, and I hope to make some progress with that. So, what are we trying to achieve? Well, the over big view was this triple aim, which is really enhance patient experience, improve population health, and reduce costs. But The burnout of our workforce threatens the triple aim. So 2 years ago from North America, they added the fourth aim, which is improve the work life of healthcare providers, including clinicians and staff. Because if you don't look after them, you've got no chance of actually achieving the other three. So that's changed in the last year, and it's something we really have to work on a lot harder. So what do we know about this problem? Well, this is what the first slide was, all those problems. It's really hard at the moment. What else do we know? There is actually a battle going on at the moment. It's not really a battle, but there is a problem because we have this relative emphasis in society on the want and need for more and more subspecialists. I want to see the real expert on this and less generalism. And this isn't general practice versus hospital doctors. Even the College of Physicians in London say we need 5,000 more general physicians because they've got too many super specialists. They haven't got enough people who can see the overview or something, and you can only see somebody. I was actually at a dinner the other day with the ophthalmologist, and they were saying, well, yes, there's two of them work together. He does the left eye, and she does the right eye. But it's true, it's already happening. So the super specialist approach to achieve the triple aim had the hospital at the centre, met the needs of patients by having more silo-based subspecialists. This has clearly failed. It's unaffordable, and people have too much treatment that they don't need. The future generalist approach for the quadruple aim includes the need and resourcing for all generalists more than subspecialists, multidisciplinary more than monodisciplinary, decentralization more than centralization, and managing uncertainty with confidence. This is a rather big ask, so this might fail as well. So the College of GPs, as you would expect, have done a lot of work on the generalist approach, the need for medical generalists, a vision for general practice. And it wasn't actually really until 2 years ago that we started to realize we haven't got enough GPs, we haven't got enough practice nurses. So last year, in the light of that, we had the NHS commissioned an independent report from Martin Rowland, who's a professor of general practice in Cambridge, looking at this problem. And really, there aren't going to be enough GPs in the future, there aren't going to be enough practice nurses, so we need staff who, with the appropriate skills, who can take some of the burden off us until we sort it out. But that's going to take 10 years. And in England, and this is England only, the other 3 health services haven't got this, the General Practice Forward View was published in April, which takes us from having about 8.5% of the NHS budget, which is almost a historic low, up to something like 11% of that budget, which equates to about an extra £2.8 billion per year for primary care. So this has been a result of the Put Patients First campaign that we've run with NAP, and there's an acknowledgement that this is happening. The problem is there's a feeling it's there, but it's not actually coming fast enough. And Scotland, Wales, and Northern Ireland haven't even got this yet. So what else do we know? Well, where are we going? There is always this discussion about, well, has the government got another agenda? I don't know. It's not a declared agenda, but there is really a sense of direction of travel whereby the sort of old corner shop GP is sort of going, and they were being federated, and we're getting into larger networks, and they have lots of names, super networks, multi-speciality community providers, primary and acute care systems, and these come together in some sort of formal organization. And these may become accountable for the cost and quality of the care. They deliver the care, they won't be commissioning it, and they will have responsibility for managing NHS budgets and can make a profit or loss on the basis of that. For instance, there is a federation super network in the Birmingham area called Modality with about 27 practices, and they are in partnership with Optum, which is part of United Healthcare from the US. And in a sense, what the benefit of the partnership with Optum and United Healthcare is that they can underwrite risk, because there's always going to be a risk associated with this, whereas the federations haven't got the experience, and they've got access to big data to predict what you need to do for patients at a particular time. But our danger in general practice is if we're going along in this direction, and general practice will change, we have to make sure we don't throw the baby out with the bathwater. What are the important things that we need to keep? And we need your advice on this. What are the important things about great primary care that we need to keep, the personal bits? So, what's to be done? Is there too much medicine? So you can either say, I don't know what to do, get to the front, hold your arms up in the air and scream and just get on with it, or tackle some of the root causes. Like, for instance, is lack of informed consent leading to overdiagnosis and overtreatment? So I'm going to talk now a little bit about informed consent. And the reason I'm going to do that is because I think, how will the future judge us now? When I look back at the start of my career as a GP, consultation skills back in 1980 hadn't actually been invented yet. We had bedside manner and it was unteachable. You either were born with it or you didn't have it. Okay? And then we discovered videos and we discovered consultation skills, and now every GP trainee has extensive education in how to do consultations a lot better. So how will the future look back on us now? And I think they'll look back at this and they'll say, what on earth did you think you were doing with things like the Quality Outcomes Framework, where we're paying GPs for achieving targets, and we haven't really explained what the benefits are for patients. So you can't really get informed consent. So I think we will be judged badly because of that. So I'm going to talk now a little bit about informed consent. So many of you will be familiar with these concepts of numbers needed to treat and numbers needed to harm. Numbers needed to treat is basically, if you've got a particular problem and I think you're at risk, how many patients need to be treated for one patient to benefit? Or, if you're treating them, and I'm treating everybody with these particular drugs, how many people will get harmed? So these are important numbers to know. Because currently we give people a sort of Hobson's choice. Hobson was a stable owner in Cambridge, and he said you could have any horse as long as it's the one next to the door. And we're sort of doing that a little bit at the moment. So if we give patients informed consent, how will this help our quadruple aim? Because that's what we're really trying to achieve. Well, I think it's bound to enhance patient experience. I think it's bound to improve population health, because we won't be giving them side effects for a start and we won't be over-treating them. And it's bound to reduce costs because we won't be using all these unnecessary treatments and tests and all the rest of it. And I'm pretty sure it will improve the work life for healthcare providers, because we'll just be seeing less people because we won't be doing all these routine tests which don't really do anybody any good. So what we're trying to do now is improve patient centeredness by improving patients' understanding of the health care choices and achieve that quadruple aim. So last year, or 2 years ago, the RCGP had an independent inquiry, which I know Patricia was on, looking at how to make patient-centered care happen, and better informed consent was part of that. So what do we know about this? This is back to those 5 questions at the beginning. What do we know about this subject? Well, the doctors don't really know the numbers needed to treat for most things, and so the patients aren't going to know them either. And patients only usually consent with a very poor understanding of their risks. And although this numbers needed to treat and numbers needed to harm information is there, it's not very easy to access. So, what else do we know? Well, patients usually overestimate the benefits of treatments and underestimate the harm. This was from a systematic review last December by some Australian researchers. Chris Delmar used to work in Britain, but now he's back in Australia. And so why do we do this? Why do we recommend treatments that aren't that good? Well, there's a huge amount of uncertainty. There's a lot of peer group pressure to do things. There's denominator neglect, which I'll talk about in a moment. There's framing, which I'll talk about in a moment. And it's the way we get paid. You know, the amount of pressure on GP surgeries in January, February, March to actually complete their QOF payments is quite strong, because it's a huge part of their income. And then perhaps, maybe we just don't know any better, and I think there's truth in that as well. What's denominator neglect? We're all really familiar with this. This is the story where we hear something that's gone wrong. You know, it might be a child kidnapped on the street or something like that, so we concentrate on the one terrible story rather than all the children that are playing on the street who are perfectly all right. So we become very risk averse because we hear about the one thing that's gone wrong rather than all the things when it went well. And we use that a lot in medicine. And the other one is framing. If you're shown a risk that emphasizes danger, you react by thinking it's dangerous. Whereas if you're shown the same risk that emphasizes safety, then you react by thinking it's safe. And I actually remember back in 1980 overhearing an obstetric registrar telling a higher risk pregnant woman about the risk of Down's baby and the risk of the amniocentesis, and saying the risk of Down's is really quite high, it's about 1 in 5, but the risks of the amniocentesis are very quite low, it's only about 20%. But we all do this a little bit. So what else do we know? Well, is consent ever informed if the numbers that describe risk remain a mystery to most people? So, it's quiz time, but don't panic. Just score yourself in a quick quiz to see what the things are. I'm going to rush through these quite quickly. Most of the numbers that are coming up are available on this American website at the bottom, where they actually work in, the actual from the research evidence where something is actually the numbers needed to treat. So we'll just start off with this. So who would take a drug to prevent an illness? Well, if the numbers needed to harm, there is no harm attached to this is 0, and the numbers needed to treat to prevent the illness is less than 5, so 1 in 5, then about only 50% would take that drug. If the number needed to treat is greater than 5, therefore only one person in maybe 10 is going to benefit from it, the numbers taking the drug double if the doctor recommends it. But we hardly have any treatments that are that good. So let's just start with a few. This is diagnostic testing if you're a low risk of the disease. Every GP does this every single day of the week. I'm a bit worried about this. Can I have a test? Okay. Numbers need to treat, numbers need to harm. Nobody gets helped in the sense of decrease in the illness concern, general anxiety or symptom persistence. 1 in 20 are less likely to come back and see a doctor again. Plus, there's an unknown numbers that people need to harm because there's lots of false positives, there's lots of anxiety, and there's lots of things associated with it. I'm going to whiz through these quite quickly. Try and think out what your numbers are to yourself, though. Routine health checks for reducing mortality and morbidity. Very popular. Private insurance companies do them. Public Health England are promoting these health checks and saying what a great thing it is. So numbers needed to treat. Nobody gets helped. Numbers needed to harm, again, unnecessary testing and treatment side effects. Prostate, specific antigen, which is to detect prostate cancer in men of a certain age, again, really quite popular. Numbers needed to treat, nobody gets helped. Numbers needed to harm, 1 in 5 were harmed undergoing a prostate biopsy for a false positive test. Actually, I was involved in one of the first studies on prostate-specific antigen. This is back in 1990. We were screening the population in our practice. The interesting thing about this is if you went through the test and had your radical prostatectomy at the time, that's what you had. But in 1990, we didn't actually have to ask for ethical permission from anybody to do that study. It seems hard now, but that was in 1990. Antibiotics for middle ear infection. It's not a mild sore throat, but a proper middle ear infection. Nobody gets helped, but you do get diarrhea if you take the antibiotics. Breast screening. There's a big breast screening campaign been going on for a number of years now. So how good is that at reducing death, and specifically breast cancer deaths? Nobody gets helped, but a number needed to harm. You get lots of false positives, and you get a lot of unnecessary surgical procedures over 10 years. Nicotine replacement therapy for smoking cessation. This is quite popular. And actually, this is quite good. How many people do you think are able to, if they're smoking more than 15 cigarettes a day and they stop smoking it at 1 year? Just think to yourself, how many people get helped by that, by the stop smoking, which we all recommend, 1 in 15. Nobody really gets harmed, though, which is good. But the expectation is that all these treatments appear to patients and doctors often to be much more powerful than they are. Statin drugs, given for 5 years for heart disease prevention without any known heart disease. So you've got a high cholesterol and you're taking your statin, but you haven't got any history of heart disease. So numbers needed to prevent death, stroke, heart attack. Got to be good, hasn't it? None were helped to avoid death, 1 in 154 to avoid a stroke, and 1 in 104 to avoid a heart attack. But that does mean 153 are taking it unnecessarily for a stroke prevention, and 103 are taking it unnecessarily for a heart attack. But quite a lot of people develop diabetes, and quite a lot of people get muscle damage as associated with taking those drugs. blood pressure medicines for 5 years to prevent death, heart attacks, and strokes. So the numbers needed to prevent death, stroke, heart attack. 1 in 125 for death, stroke 1 in 67, still means 1 in 66 are taking it unnecessarily, heart attacks 1 in 99. Side effects of medication for blood pressure are really, they're every single day in a GP surgery that you've got people with side effects from these drugs. Tight blood sugar control for 5 years in people with type 2 diabetes. So that means they don't need insulin, they're just on medication for usually oral medication to control their blood sugars. Death, heart attack, stroke, kidney amputation. No less deaths, no less heart attacks, no less strokes, no less kidney failure, but 1 in 250 may have less of a problem with limb amputations. But a significant number get severe low blood sugars, hypoglycemia, needing to go into hospital. Coronary artery stenting, this is putting in this little tube in your arteries around the heart to unblock your artery. This is for non-acute coronary disease, that's angina, compared to medical therapy. Nobody gets helped. So, I think it's fairly clear that these numbers aren't really well known, either to the doctors or to patients. And I think as a result of this, we are probably over-investigating, over-treating, over-medicalizing, over-giving people side effects from their medication. And we have to sort of redress this somehow. So I'm pretty sure that we will achieve our quadruple aim partly by addressing this sort of thing. So what's to be done? What can we actually do with the resources we've got? That's the third question in how to improve quality. So we need to make these risk scores for numbers needed to treat and number needed to harm for all the tests and treatments much more easily accessible. The website that I quoted there, the NNT one, there's a small number there, but it's not a huge number. The other one I use is a subscription one, Essential Evidence Plus, but you can't, they're really quite difficult to get out of the system, but they are known. But it's very difficult to actually easily access it, particularly when you've got a patient in front of you. Then, of course, we are all different, and GPs and patients need to benchmark their own understanding and tolerance of risk and make that clear. So I have a certain tolerance of risk, and you have a certain tolerance of risk, and we've got to come to a compromise and know what it is to work out what's the best treatment for you. Because some people will feel a 1 in 10 risk is unacceptably high, and some people will think, I'm not really that bothered. So we are all different. And then if patients are better helped to understand their risk, then they should make more informed and personal choices about their care and quite often decline care. So we have to respect informed life choices much more. And the evidence is that people, when they know what the risks are, they actually decide not to have treatments because they're much more interested in other things. Where you come in again here is good feedback. So you have to be giving feedback to the caregivers, the doctors, the nurses, about really, what are you telling me? I really need informed consent here, because your feedback will make a difference. So, this is down to the next question, but how can we spend more time with patient findings and explaining all this when we've still got all these problems, we're overworked and all the rest of it? This is the same list from the beginning. Well, for GPs, all we've got to do is start. Just start with one patient a week, first patient on Monday morning, and see how it goes. We don't have to do it for everybody, we just have to start. And for patients, I think it's the question asking, what are the NNTs, what are the NNHs relevant to your care, and making more informed choices. Just asking those questions will actually be worthwhile. And then how will we know who you've been successful? Well, you've got to agree, what success is. So what's a good personal, local, national, or international measure? There are some national and international measures already. So, for instance, the Commonwealth Fund takes a sort of a global view of different countries, and I'm sure you've been aware that for the last 2 years from their last report, Britain has come sort of as the top healthcare system. We weren't before that, but obviously when you're number one, there's only one place you can go. So presumably the next time we won't be number one and they won't be talking about it so much, but currently we're number one. And they have got various issues there about how patient-centered we are. But it's back down to how will we know if we've been successful. So you have to work out yourself what is good personal or local measures of success, something that matters to you. It's the difference between what matters to you medicine rather than what's the matter with you medicine. We're doing what's the matter with you, but we want to actually make it what matters to you medicine. And then you have to ask, what is this intervention that I'm being offered, this extra test, this extra drug, is it really going to improve your own work life or enhance your patient experience? And you have to ask yourself clearly about that, what's important to you. And how and when are you going to review what you're doing? Well, that's for you to decide. I'm not going to talk about that today, but you do need to review it because, as we know, everything moves on, changes, evidence changes. If I asked everybody in the room, what's the perfect diet, we'd have 110 different answers because it's just so difficult for anybody to know. So that's it. They were a little bit worried because I had so many slides, but I did reassure them that I'd get through them all. So I have question and answers. We can leave that, but I have got a few you might like to ask later on when we get to this point of the meeting. Thank you.
Thank you very much, Terry. I think we have time for just one or two quick questions if anybody wishes to put them.
Patricia Mayo from Worcestershire, Haresfield Surgery. Terry, I really enjoyed your presentation. However, whilst doctors are paid on results, I can't see the situation ever changing. And in Worcester, we're under pressure to get our prevalence up for some groups of patients. So it's almost like we're being encouraged to medicalise more patients, and I just wondered how you thought, whether this is going to change all this target-driven stuff for GPs.
Yes, it is going to change. In the Lancet 2 weeks ago, there was a report on how payment for results, QOF payments in the UK, what effect that's had on mortality of those patients, because we've been doing it for 10 years. And the result from the Lancet is that it's made no difference at all to mortality. So apparently, we think that we're doing good, but actually we're probably not. And I think in the future, what we'll be doing is targeting better the patients who really do need the tests and interventions, rather than the general public who actually probably don't need them.
Okay, well, thank you very much for a really stimulating and challenging talk. And if anybody has further questions, then there will be an opportunity for the panel. Thank you very much indeed, Terry.